Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel of Stand Medical Notes and Lecture. So let us discuss some practical examples and how to manage a case of type 2 diabetes mellitus in different conditions. So let's begin with the name of Almighty. So case number 1. A case of type 2 diabetes mellitus with no comorbidities, with no focus, a baseline case. So patient centered, so target HbA1c less than 7%. So in general population it is less than 7%, as you know, as you have studied. So a 48-year-old male with BMI of 33 kg per meter square has lab values of HbA1c 8.8%, fasting plasma glucose of 185 mg per deciliter. Renal function eGFR is 95, which is normal, but these two are raised. Comorbidities, patient is known case of essential hypertension but no established cardiovascular disease. So not should be the clinical decision. So there is no renal compromise, there is no cardiovascular disease, but slight obesity is there. Okay, so clinical decision is intensive lifestyle modifications with diet and exercise with concurrent first line pharmacotherapy, and target HbA1c is less than 7%. Okay, coming how we will manage first line therapy. So you should initiate metformin first. What does metformin do? It will lower the hepatic glucose, that is the goal. Lower hepatic glucose output and improve the peripheral insulin sensitivity both. So the drug of choice is metformin. Key rules to remember is start low, go slow. You start with this low dose and titrate slowly to mitigate adverse effects like diarrhea and nausea, and take the drug with the largest meals of the day. So how it should be taken? Patient's metformin titration schedule: week 1 500 mg once daily with dinner, week 2 twice daily with breakfast and dinner, week 3 1000 mg morning and 500 mg evening. So till here patient will tolerate well, all the patients will tolerate well. So this increase in the third week, the dose should be increased if the patient is still tolerating. Okay, at 1000 dose, if the patient is tolerating, then you can increase still, but if the patient is not tolerating, then stop at this dose only. Okay, so that means you should increase the dose of metformin to a maximum of 2 gram per day, or to the point at which the patient can tolerate. So in this patient, the third week it is 1000 morning and 500 evening. Week 4 it is 1000 twice daily. So this is the maximal effective dose that is achieved in this patient. So if significant GI distress occurs at any step, drop back to the previous tolerated dose for an additional week before attempting to increase again, or switch to an extended release formulation of drug, meaning metformin. That means our goal is to increase metformin to the maximum dose, that is 2 gram per day, either by slowly increasing the dose or by using extended release formulations. So as we have discussed, so it reduces the hepatic glucose production and improves the peripheral insulin sensitivity. GI side effects are nausea, diarrhea, abdominal discomfort. So these are usually transient and dose related. So this will go with time. That was the phase 1. Now coming to the phase 2, re-evaluation is step up. Now after giving maximum dose of metformin, we will add a GLP-1 receptor agonist. So scenario 3, after 3 months. So we will wait for 3 months. Now after 3 months we have taken history and patient is tolerating metformin well, 1 gram twice daily. Now new lab investigations after 3 months, HbA1c is reduced. Now it was 8.8%, now it is reduced to 7.9%, but still it is above the target because our goal is less than 7%. Okay, so what is the clinical decision? So dual therapy is indicated given the patient's BMI of 33 kg per meter square, and add an agent with high glycemic efficacy and significant weight loss effects. So that is semaglutide, which is a GLP-1 receptor agonist. So it should be given subcutaneous once weekly. So now week 1 to 4, the dose should be subcutaneous dose 0.25 mg. So this is the initial dose, not for glycemic control, purely to build GI tolerance. So stay on 0.25 mg weekly for 4 weeks to minimize nausea and vomiting. From week 5 to 8, that means in the second month, increase the dose to the 0.5 mg. So this is the first therapeutic dose, and then assess the tolerance of the patient. If tolerated, increase to 0.5 mg weekly. If severe nausea, delay the next increase. Now in the third month, from week 9 to week 12, increase that means double the dose. So 0.25, it is double to 0.5, then 0.5 to 1. So in the third month, increase the dose to 1 mg. So this is the target therapeutic dose, and monitor HbA1c and weight reduction. Continue 1 mg weekly and reassess in 3 months. After week 12, meaning in the 4th month, one can increase from 1 mg to 2 mg. It is an optional dose increment. So this dose increment from 1 mg to 2 mg is indicated if HbA1c remains still above 7% after 3 months at 1 mg subcutaneous dose. So maximum dose is 2 mg. So already we know how GLP-1 agonists work. They enhance glucose dependent insulin secretion, they slow the gastric emptying time, and they cause increased satiety. They promote weight loss. Common side effects are this one: nausea, vomiting, decreased appetite, diarrhea, which is usually transient and dose dependent. So important thing is strict and gradual dose escalation every 4 weeks to prevent severe GI side effects. So we have now after 6 months, what is the patient? We will see now. So after 6 months, the scenario is 6 months, patient is on metformin 1 gram twice daily with semaglutide 1 mg once weekly. So patient has weight loss of 6 kg. New lab investigations, HbA1c is still 7.4%, and fasting plasma glucose is now achieved. We have achieved the target of fasting plasma glucose, that is 125 mg per deciliter. What is the clinical decision now? We are close to goal, but still slightly elevated, and a third agent with a complementary mechanism that does not cause weight gain or hypoglycemia should be added. So that is SGLT2 inhibitor. So drug of choice is either dapagliflozin or empagliflozin. Dapagliflozin dosing is 10 mg once daily in the morning. No complex titration is required for glycemic control. Counseling points, important point here is SGLT2 inhibitor, they cause osmotic diuresis. Now that's why patients should be informed to maintain adequate oral hydration, and because glucose is excreted more through urine, patient should be informed to maintain a strict perineal hygiene. So this will reduce the risk of genital mycotic infections like genital thrush, yeast infections due to glucosuria. And maintaining adequate oral hydration helps prevent volume depletion, dizziness and hypotension. So we already know how SGLT2 inhibitors work by inhibiting SGLT2 channels in the proximal tubule of the kidney. Common side effects we already know: genital mycotic infections and increased urination. Okay, so final regimen. So this is the optimized triple therapy. Final regimen: metformin 1 gram twice daily, 1 mg subcutaneous weekly semaglutide, dapagliflozin 10 mg once daily in the morning. So this is a triple regimen. Now what's next then? So if the HbA1c remains still more than 7% on this optimized triple therapy after another 3 to 6 months, the next step would be the introduction of basal insulin. The next step would be the introduction of a basal insulin. So this is how we give an medication therapy for a patient with type 2 diabetes mellitus without any comorbidity and without any focus. A baseline case of type 2 diabetes, how it is managed here. So one thing I should inform you here is, whenever the HbA1c is more than 1.5%, we have already learned this, 1.5% above the target value of HbA1c, then there itself combination therapy is required. Here you see the patient had 8.8% HbA1c, but target was 7%. So if you add 1.5 to 7, it becomes 8.5%. So already the patient was 1.5% more than the target. That means it should be presumed, it should have been presumed that patient will require combination therapy. Okay, so what we have done, metformin maximum dose, then GLP-1 agonist semaglutide, then SGLT2 inhibitor, like that. Okay, so this is a baseline case. First case we have discussed. So let it be, I will rub it. Now coming to the second case. Now here is a case, a patient with type 2 diabetes mellitus who has established atherosclerotic cardiovascular disease, maybe angina or coronary artery syndrome, like that. But patient does not have any heart failure. He has coronary vascular disease but no heart failure. So Mr. Patel is a patient who is 58-year-old male with a history of MI 3 years ago. He has just been diagnosed with type 2 diabetes mellitus. Baseline investigation HbA1c is 8.6%. Okay, it is 58-year-old. Okay, so the target will be decreased. Now it will not be 7%, and FPG is 175 milligram per deciliter. eGFR is normal, more than 90. There is no signs of heart failure on echocardiogram. Clinical goal is lower the HbA1c to less than 7% and use medications proven to reduce the mortality associated with cardiovascular event, MACE. Okay, here he has given 7%, but seeing the age of the patient, that is 58-year-old, and in this example, and he having comorbidity, so we should keep a goal of 7.5 to 8% actually. Okay. Now how we will start the medication? Again here also 8.6% target value. It is more than 7.5% more than 7%. So he will require a combination therapy because he has a comorbidity of MI. Because Mr. Patel has established atherosclerotic cardiovascular disease, therapy must include an agent with proven cardiovascular benefit independent of HbA1c. Metformin with semaglutide. Okay, so metformin is insulin sensitizer which reduces hepatic glucose output. Semaglutide is chosen for strong evidence in reducing mortality associated with cardiovascular events and weight loss benefits. Now, initiation of therapy. Weeks 1 to 4, that is to build tolerance. Okay, because both metformin and semaglutide, they cause gastrointestinal side effects, nausea and diarrhea. So start metformin with 500 mg once daily with dinner, last meal, and semaglutide GLP-1 receptor agonist start with 0.25 mg subcutaneous once weekly. Okay, step 2 is oral titration first. So we are taking time to titrate this semaglutide. We are titrating first metformin. We are starting combination, but we are titrating first metformin. We are giving one month time for semaglutide so that our GI system gets adapted to it. So maximizing the dose of metformin. Week 2, give 500 mg BD with breakfast and dinner. Week 3, increase the morning dose if tolerated. Otherwise, you go to the previous dose and wait for one more week, then you increase the dose. Okay. Then week 4 is 1 gram twice daily. So that is the target dose, so which is achieved. But continue semaglutide 0.25 mg subcutaneous once weekly in the first month, week 2 to 4. Okay. In the meantime, these should be monitor for fasting plasma glucose and gastrointestinal symptoms. These two should be done. Now step 3, in the second month. Already metformin we have achieved the maximum dose, that is 2 grams. Okay, twice daily. Now we should titrate the dose of semaglutide. Increase the dose of semaglutide 0.5 mg subcutaneous once weekly. Okay, this is the first therapeutic dose that provides meaningful glycemic lowering and cardiovascular protection. So remain on 0.5 mg dose for next 1 month. Now in the third month, metformin is continued as usual, 2 grams per day divided doses. Semaglutide increased to 1 mg subcutaneous once weekly. Okay. Key points: patient notes mild decrease in appetite. Maintain this dose with metformin. Now in the this is the second month. No, now in the third month, follow-up investigations we will do. So now HbA1c, you see it is 6.8%, which is less than 7%, very much low. And fasting plasma glucose average is 110 milligram per deciliter. Again, target is achieved here also. And there is a weight loss of 4 kg. So conclusion here is Mr. Patel has safely navigated the titration phase without severe GI adverse effects. He is now on a stable, optimized regimen that controls his blood glucose while actively protecting his cardiovascular system from secondary ischemic events. Now, one question I will ask here. Actually, this semaglutide GLP-1 receptor agonists are very costly. Okay, so in country like India or in any developing or backward country, you can already it was discussed in pharmacotherapy. If GLP-1 agonist is costly or not available, you can switch over from GLP-1 agonist to SGLT2 inhibitors. If this is not available, then you can shift to this one, combination therapy, as a combination therapy. But first line in cardiovascular disease, semaglutide. But GLP-1 agonist, if they are not available, then you can give SGLT2 inhibitors. Okay. And in one special important point in SGLT2 inhibitor is they don't require any dose titration. Now the final conclusion in this case, Mr. Patel is stable on optimized regimen is metformin 2 gram per daily with semaglutide 1 mg subcutaneous once weekly. So glycemic control, cardiovascular protection, weight management is achieved. Now what should be the follow-up? Monitor HbA1c every 3 months, monitor weight of the patient and BP of the patient, reinforce lifestyle measures like diet and exercise, monitor for any side effects. Okay. If HbA1c rises above target, like more than 7% on this regimen, consider intensification. Add a SGLT2 inhibitor for additional cardiovascular and renal benefit, or other agents as appropriate. Now coming to a third case. Okay, so this case is practical. Is a patient of type 2 diabetes mellitus with heart failure. Now how you will manage in this patient? So that was MI actually. So MI, there also target should be less than 7.5%, but that they have given 7%. Here you see, here is a patient named Ramirez, who is 65-year-old, so elderly aged, more than 60 years of age. 65-year-old male with known heart failure with reduced ejection fraction. So ejection fraction is 35%. He is stable on guideline directed medical therapy. So guideline directed medical therapy, as you already know, it is number 1 ARNI or AC inhibitor or ARB. Number 2 is beta blockers. Number 3 is your mineralocorticoid antagonist. Number 4 is SGLT2 inhibitors. So these 4 constitute the guideline directed medical therapy. Okay. So baseline labs, HbA1c is 8.2%. Fasting plasma glucose is 160, above the target. See, eGFR is also reduced here. It is 55 ml. So that means patient is also having CKD. So heart failure status, HF ejection fraction is 35%, stable on ARNI, beta blocker and mineralocorticoid receptor antagonist. Now the goal is lower HbA1c to a safe target less than 7.5% because of age and comorbidities. Using meds proven to reduce HF hospitalizations, okay, and cardiovascular mortality. So after MI, if the ejection fraction is reduced, the main thing is frequent hospitalizations for heart failure. So that we should reduce. Okay, that we should reduce. And other thing is reducing the risk of atherosclerotic cardiovascular disease also. Now the step 0. So what is the step 0 now? Starting line and crucial agent selection is important. So in patient with established heart failure, guidelines mandate the use of an SGLT2 inhibitor as first line therapy independent of baseline HbA1c. So you should start as a combination therapy. So dapagliflozin plus metformin. Okay. You should remember what are the absolutely contraindicated drugs in these patients with heart failure. So avoid drugs which cause fluid retention and worsen heart failure. So there are two drugs. So thiazolidinediones like pioglitazone and DPP4, not all DPP4 inhibitors, only one, that is saxagliptin. So pioglitazone and saxagliptin should not be given to patients with CKD, because CKD also there is water volume overload state. So CKD and this, in this case, saxagliptin and pioglitazone are absolutely contraindicated. Now coming to initiation, week 1. So start combinedly. Dapagliflozin 10 mg once daily in the morning, metformin 5 mg once daily with dinner. Start low to minimize GI upset, nausea and diarrhea. Instruction to be given: hydration, perineal hygiene, daily weight monitoring. Okay. A sudden drop may indicate over diuresis. If the weight drops suddenly, that may indicate over diuresis. Okay. Because the patient is heart failure patient, he may be on furosemide. Okay, he may be on furosemide, and this SGLT2 inhibitor is also a diuretic. That's why this patient may require a loop diuretic adjustment, that patient should be informed that you should consult if you have a sudden weight loss. Okay, now coming to from week 2 to 4. So week 1 5 mg once daily, week 2 5 mg twice daily. Now in week 2, what you are doing is, you are doing in the week 2 one investigation, so that is EGFR. So the reason we will understand here, EGFR checked in this patient has dropped from 55 to 48 now. So but that is not a point of concern, because this is an expected effect. This is a benign hemodynamic effect of SGLT2 inhibitors. There is decreased in the intraglomerular pressure. Okay, that's why there is expected decrease in EGFR from, so that's why here it is decreased from 55 to 48. So that means if you, when you give a patient with SGLT2 inhibitors, so in the second week you should measure EGFR, okay, in a patient with CKD, because there is a expected 20%, I think, yes, 20% up to 20% decrease in EGFR. So week 4, so morning it is 1000 and evening it is 500 mg metformin. So increase to maximum tolerated effective dose based on EGFR if no significant GI distress. But one point to remember here is, if the patient is already in CKD G3B, meaning the GFR is less than 45, then the maximum titration dose for metformin is not 2000, meaning 2 gram, it is 1 gram per daily only. You should not go to 2 gram. Okay, and also we should have in mind that these CKD patients already they have GI side effects because of uremic gastropathy, so that's why they tolerate less. So see the patient and then titrate the dose. So monitor fasting plasma glucose, monitor the weight, monitor the EGFR and electrolytes, and report if any symptoms of volume depletion occur, like dizziness, lightheadedness, low BP. Now continue 10 mg once daily in the morning. No titration is needed, as I said. So SGLT2 inhibitors does not require any titration. So one thing is, in the second week you should measure EGFR, because there is expected drop in EGFR 20%, less than 20%, so it should drop. Okay, so in third month you do all the investigations now to see whether the goal is achieved. Most important investigation is FPG and HbA1c for glucose control, and because the patient is having CKD, so you should see EGFR also. So after 3 months, the results are HbA1c is less than 7.1%, so the target is achieved, so it is less than 7.5%. Fasting plasma glucose is 115, so it is less than 130, so the target is achieved. EGFR is stable, so in the third month EGFR is not fallen less than 48, it is between 48 to 52. Okay, so no worry. So heart failure status, patient feels less congested, patient is experiencing improved exercise tolerance, and loop diuretic requirement is slightly decreased. So the conclusion is, Mr. Ramirez is successfully stabilized on a regimen that controls his blood glucose and improves his heart failure trajectory and survival odds. So the final regimen is dapagliflozin along with metformin. Okay. Why this works? SGLT2 inhibitors provides critical heart failure benefits beyond glycemic control. Metformin safely lowers blood glucose without causing fluid retention. Always avoid pioglitazone saxagliptin in these patients. In HFrEF, think SGLT2 inhibitors first. They are disease-modifying therapy for the heart and kidneys both, in addition to lowering blood sugar. So this patient has both CKD and heart failure. Okay. Now moving to the fourth case. So a patient of type 2 diabetes mellitus with CKD. So here is a patient named Mrs. Gupta, 64-year-old female with long-standing hypertension, type 2 diabetes mellitus, and her recent labs show declining kidney function. So hypertension is also there, diabetes there, and CKD is also there. eGFR is 42 ml, so it is 3B, stage 3B. And if you measure UACR, urinary albumin creatinine ratio, there is macroalbuminuria. So that is a marker of nephropathy and retinopathy, microvascular damage. Okay, so macroalbuminuria. HbA1c is 8.3%. Current medication, she is on metformin 1000 mg twice daily, and ARB, that is low sartan 50 mg once daily. Now our goal is to lower HbA1c less than 7.5% safely while using medications that provide renal protection and slow progression to end-stage renal disease. So any patient which is having comorbidity, we are starting the drugs combination therapy. Okay. Starting line, mandatory adjustment. So Mrs. Gupta regimen must be adjusted due to her declining eGFR. New guideline directed therapy for kidney protection is required. Because the eGFR is between 30 to 45, so 2 gram per day increases the risk of lactic acidosis. That's why metformin should be reduced to a maximum dose of 1 gram per day only. Okay, that one we have done. So other important thing is avoid nephrotoxic drugs like NSAIDs and continue low sartan. This information should be given, should have given to this patient. So that is a ARB for kidney protection. Keep BP in control and monitor potassium in this patient. Now renoprotective drugs you should add. So add SGLT2 inhibitor dapagliflozin 10 mg once daily in the morning. So it is indicated for CKD with albuminuria for kidney protection regardless of glycemic benefit. And same instruction should be given: perennial hygiene, hydration. And one more thing is sick day rules. What is this sick day rules? If this should be said to the patient, if you have a severe illness like vomiting, diarrhea, fever which causes a lot of fluid loss from the body, or cannot eat or drink, stop dapagliflozin temporarily and contact your doctor. This helps prevent euglycemic diabetic ketoacidosis and acute kidney injury in the patient. Okay, acute kidney injury is very important. So continue metformin 1 gram twice daily and low sartan 50 mg once daily. Second step is in the 4th week. Okay, so in the previous case we have seen already in the 2nd week we have measured actually the eGFR. Here we are measuring, in this patient it was measured 4th week. So eGFR measuring. So eGFR dropped from 42 to 37. So it is 12% drop. So reassure the patient an initial drop in eGFR up to 30% is expected and benign hemodynamic effect of SGLT2 inhibitors. Do not discontinue. This should be given. So I said 20%, but here it is 30%. Some books say 20%, some books say 30%. You can take any one of them. So less than 20 to 30% decrease should be there. Okay, so it is 12% actually. What to monitor? Monitor eGFR, monitor potassium level and magnesium levels and electrolytes, blood pressure and volume status, blood glucose, and UPCR over time. Now the therapy is dapagliflozin 10 mg, metformin, and low sartan. Now re-evaluation is done at the 3rd month. 3rd month UACR improved from 550 to 280 mg per gram. So renoprotective effect is evident now. HbA1c dropped to 7.8%, but still above the target. eGFR is stable. It is not decreasing. See, it is 37 only. Now the dilemma. Metformin is maximized for her GFR. Yes. SGLT2 inhibitor is at its therapeutic dose, that is 10 mg Now she needs a third agent because target is not achieved. So agent selection, the agent should be require zero renal dose adjustment, and it should be safe in advanced CKD. So avoid sulfonylureas in CKD patients because they have a high hypoglycemia risk in CKD. Avoid complex titration. Now the third action is add a DPP-4 inhibitor again. DPP-4 inhibitor. Here linagliptin is chosen. Why? Because it is safe on all GFR, all EGFR. So linagliptin is primarily excreted via bile. It requires zero dose adjustment regardless of EGFR. Okay. So now the regimen is metformin 1 gram daily, dapagliflozin 10 mg OD, linagliptin 5 mg OD, and losartan 50 mg OD. Now the final assessment again after 3 months, that is, and the 6 month. Now the HbA1c we have achieved the target 7.1%. EGFR is 38%, is stable, it is not decreasing. Okay. UACR, it is 210 milligram per gram and continued improvement. So it was 280 previously, now it has come to 210. Clinical outcome is glycemic targeting achieved, kidney function stabilized, and albuminuria reduced. Risk of progression to end-stage renal disease is slowed. So Mrs. Gupta feels well now, has good BP control, and continues regular follow-up and lifestyle measures like diet, exercise, and no smoking. So the regimen is now metformin 1 gram twice daily, dapagliflozin 10 mg once daily, linagliptin 5 mg once daily, and losartan 50 mg once daily. Okay. Now some clinical pearls. SGLT2 inhibitors are foundational therapy for CKD with albuminuria. Expect an additional dip in EGFR less than 30%. It means the drug is working. Adjust metformin dose based on EGFR to reduce lactic acidosis risk. DPP-4 inhibitor linagliptin is ideal add-on in CKD. Safe, simple, and no dose change. When to seek help? Persistent nausea, vomiting, diarrhea, or dehydration, seek help. Signs of genital infection, seek help. Unexplained fatigue, swelling, and reduced urine output, seek help. Any illness requiring poor oral intake, follow sick day rules. That means temporarily start this SGLT2 inhibitors. That is, and also this one, ARBs also. That is, we will know what is sick day rules. Okay. Okay. That was the fourth case, I think, no? Yes. So these were the 4 cases. I think it is enough for today. So a baseline case, a case with atherosclerotic cardiovascular disease, a case with heart failure, and case with CKD. So next, based upon the focus, we will discuss on the next video. Thank you.